Let us start this fantastic evening. Good evening, everyone. And this is our first topic in the series. And this is the approach to a cyanotic infant. I just made in a way very simple so that it is an overview of how do you approach a baby who is blue. I'm as a conflict of interest, I'm a co-chair of a Focus Neo organization, and this is a non-profit organization in Canada. Other than this, I have no other conflicts to disclose. The objectives of my presentation now is to assess and recognize a cyanotic infant, develop a differential diagnosis, and identify what immediate investigations need to be done, and come with a management approach to manage the baby, and a small note on critical congenital heart diseases screening program. We start with the case scenario. I will introduce the lovely girl, Mrs. Sarah. She is born today. She is 2 hours old, born as a term baby with birth weight of 3.9 kg. And you are a resident on your NICU rotation, if you imagine, and you are called to assess Sarah. She appeared blue since delivery with no improvement since then. You assessed her. Her temperature is 37.9 degrees Celsius. She is tachypneic with the respiratory rate of 110. Her SATs were down to 85 on room air. She is tachycardic at 177 beats per minute with a normal blood pressure. You got a quick history. It is an uncomplicated pregnancy with regular prenatal checks. And she was delivered vaginally to a primary mom with the rupture of membrane for 12 hours. She was a GBS negative, serology protective, and has no other health conditions for the mom. The abgars were 4 and 6, and the amniotic fluid was dark in color. On examination, there is no dysmorphic features. Baby is blue with moist mucous membranes with dusky skin. And you found there is nasal flaring, mild intercostal retractions, but no stridor. Air entry is decreased bilaterally with coarse crepitations by auscultation. Heart sounds are normal, no murmur, and normal femoral pulses, no radiofemoral delay, no hepatosplenomegaly. She is moving her all limbs symmetrically, and her neurological examination is intact. The rest of the examination is unremarkable. So this is a sample scenario. How do you proceed from here? What are the things that it is coming up in our mind to rule out? So to start with, what is cyanosis? The cyanosis is a term come from Greek, and it means a dark blue. It's defined as a dusky to bluish hue in a patient. And what causes cyanosis is the oxygenated hemoglobin versus a reduced hemoglobin. If the reduced hemoglobin is the quantity is higher, it causes a bluish to purple in color. In order to show the cyanosis, this reduced hemoglobin should be minimum 3 to 5 grams per deciliter in content. So this is an example. So if a baby is born with a normal hemoglobin level and a high hemoglobin with polycythemia or anemia, so in order to show, you need minimum 3 to 5 grams per deciliter of reduced hemoglobin. In an average, we took it as a 4, and the same we have made it. And in order to see cyanosis in a baby who is a polycythemic, even if the SAT saturations are coming down to 87%, you will find the cyanosis here in polycythemic babies. But the same, when you come to anemic baby, you will not see the cyanosis until your SATs are down to 62%. So that is what we need to understand. Cyanosis doesn't mean a sign which says that this is the starting point. You might find cyanosis in very early with the SpO2 or very late with the SpO2 detection. So only SpO2 is not reliable to look at the cyanosis only. And look at the oxygen dissociation curve. In newborns, you have more hemoglobin F, so your oxygen dissociation curve is shifted to the left. So in adults, that we want as desired PaO2 around 80, but it comes down to pediatric to 60 to 70, and newborns it comes down to even 40. When you look at even in 40, if this curve is shifted to left, you can see even up to 90% oxygen saturation. That is because of hemoglobin F. So when you look at a baby is saturating well, and or if it is saturations are coming down, we need to look at the hemoglobin concentration and also what is the PaO2 to go further. So it is, you cannot just rely only on the cyanosis clinical sign or only on SpO2. We need to look at everything together. So now coming to the types of cyanosis. What are the types are there? Most commonly we see the peripheral cyanosis. It is a normal transitional cyanosis where you will see peripheral like hands and foot and fingertips and sometimes the oral without involving tongue and mucous membranes. And this is a transitional, and it is due to peripheral vasoconstriction. And just you need to start just to reassure the parents and rewarm the baby. That's it. And the central cyanosis is the actual cyanosis what we are dealing with. It's due to arteriolar desaturation, and it is a non-specific etiology. We have to come with the strategies to define and diagnose what is the etiology causing the cyanosis. You'll see the trunk, tongue, mucous membranes are all blue. And you will see the reduced oxygen saturation, and immediate evaluation is needed. When you look at the SATS probe in the peripheral cyanosis, you'll find normal saturation. The next two are the differential and the reverse differential is all purely for cardiac critical heart disease, where in differential cyanosis is with the coarctation of aorta or interrupted aortic arch with the presence of PDA. You see the coarctation and the pulmonary artery is supplying the lower half of the body. So the upper body is pink, the lower body is blue. That is the differential cyanosis. You have the similar picture with the TGA. Opposite is upper body is blue and the lower body is pink with the TGA with the similar pathology. So basically, we are dealing with either just a peripheral cyanosis, which is transitional and normal, or you have a critical serious cyanosis that we need to look into how do we differentiate. So now we broken down to what are the issues or disorders causing the cyanosis. We have 4 group of disorders. One is the respiratory, and second is the CNS disorder. Third one is hematological disorder, and fourth one is cardiac disorder. In the respiratory disorders, you have upper airway and the lower airway. In upper airway, like a chynotresia, so we do see partial or complete chynotresia, and the baby become blue, and you will see improvement when the baby start to cry because you open the mouth, and also when you pass NG tube that it doesn't go. And you see some upper airway anomalies like microarrhythmia or periorbic sequence, and those babies, they do better with the prone position. And that is a differentiating point. And laryngomalacia, trichomalacia, they get more distressed or more grunting, more stridor during agitation or crying. And also we see congenital vocal cord palsy or occurred, and same subglottic stenosis also as part of the respiratory disorders causing cyanosis in upper airway obstructions. And most common, we are dealing with the pulmonary pathology, like a respiratory distress syndrome, pneumonia, TTN, mechonym aspiration, and pneumothorax or PPHN, or congenital anomalies like CDH or congenital pulmonary sequestration or congenital pulmonary CPAM, congenital pulmonary airway malformation or lobar emphysema. So these are all the first more common causes we deal with in respiratory disorders. But however, we need to rule out to keep in mind the other disorders causing cyanosis. So next is the CNS disorders, where you see a baby is depressed and shallow breathing, and cyanosis where majority is a higher level of respiratory center stimulation associated with encephalopathic pictures. It could be HIE, it could be metabolic, it could be anything. It could be traumatic delivery, have intracranial hemorrhage, or the baby has a seizure disorder. And basically it causes like an apnea, shallow breathing, hypoventilation, and cyanosis. And the other disorders are hematological disorder, primarily the methemoglobinemia. When you see methemoglobinemia, it's a very rare disorder, but you need to keep in mind. And when you see a baby who is blue and was not having any distress, but you have a PaO2 is normal with the low saturation, that you need to suspect methemoglobinemia. And polycythemia, when you as I said, that the detection of cyanosis is very sooner, because as soon as you desaturate to 87%, like you start seeing the cyanosis. And also the polycythemia leads to hyperviscosity syndrome. It slows down the perfusion. And the most critical thing is the CVS disorders. That is the 5 T's. It's a mnemonic. We learn about 5 T's, but now it is more T's. Like a 6th T is the ton of T's. Like you have several other cardiac conditions like a single ventricle, hyperplastic left heart. There are many things that can also contribute to the critical cyanotic heart disease. So how to differentiate these causes? First and foremost, important thing is getting a relevant clinical history and basic investigations. And please give more importance to the physical examination. All vital signs, including pulse oximetry, pre-ductal and post-ductal oxygenation or oximetry readings. And do some basic like blood gas and arterial pre-ductal, CBC, lactate, glucose and calcium. And that is a very basic workup required to differentiate. And go for this next level of X-ray and ECG, and more definitive diagnosis is through the echocardiogram. So this is a sample of a history, taking history from maternal history, maternal medications, and how the ultrasound findings in the fetus and the labor and delivery and the immediate postnatal, all these relevant history lead to a suspicion of what is the most likely diagnosis in the picture. I don't have to go through in the entire list, but this is what is the overview. The second is a complete examination. We need to look at the dysmorphism. Maybe we are dealing with trisomies or any severe growth restrictions, and looking at the complete neurological examination and neonatal reflexes, how the baby is behaving and depressed. Looking at the upper airway assessment, what we discussed, all upper airway, you can have a little bit more time, can easily identify and differentiate with the upper airway issues. Auscultate the heart and lung, and look at the perfusion, whether it's the capillary refill time is normal or prolonged. Examine the abdomen, will give a clue, like a scaphoid abdomen, it will give a clue for CDH or congestion, like a congestive heart failure. You have enlarged the liver and spleen. And examine for like a temperature and for pallor and polycythemia, and give importance to assessing the pulses. Femoral pulses equal, whether it's equal or radiofemoral delay, all the minor basic things we need to do. And don't forget to record all 4 limb BP, look for upper limb, lower limb difference, and pulse oximeter pre and post ductal. And some of the examination may give you a little bit clue about cardiac versus non-cardiac issue. So if a baby with a tachypnea with respiratory distress and has a mild cyanosis and is a uniform cyanosis, and has some upper respiratory or lower respiratory symptoms like stridor, nasal flaring, grunting, and workout breathing, examination revealed some crepitations, improving with crying, and normal to borderline perfusion, and responsive to oxygen therapy, like hyperoxia test, and presenting early, like usually at birth. This is all like, indicating, like not definite, but it is, moving, it is showing that it is, might be a non-cardiac. However, in the cardiac, a baby who has a tachypnea but a less distressed, like a happy or fast, easy breather, and the cyanosis is a uniform, or if it is a critical heart, there is a differential cyanosis. With the lung auscultation is normal, or you have a murmur in cardiac examination, and worsening with the crying, and a pale or shocked looking or poor perfusion, no or minimal response to oxygen therapy, and presenting a little bit later, like after 24 hours. It's all like indicating could be a cardiac cause or not. And some basic lab work also it can give, that you can look at the low pH with the high CO2 and predominantly respiratory acidosis might indicate towards the respiratory cause, and low pH with the normal or low CO2 with the predominant metabolic acidosis might indicate a cardiac. Similar to there's a worsening lactate level also indicate the cardiac. And the hyperoxia test is passed in non-cardiac and failed, that is less than 100 in cardiac cause. Then move on to taking the X-rays. When you look at the X-rays, always look at the situs, whether it's a situs solitus or it is only dextrocardia in situs solitus or situs inversus totalis. Locate the stomach, liver, and heart, and look at, make it as a habit to look at complete from skeleton to lungs to the heart. A small heart might be hypovolemic heart, or there may be lung might be overinflated with the PIE or congenital lobar emphysema. The cardiac position and the chamber enlargements, you can look at what are the chambers forming the cardiac cell house, and where is the aortic arch sidedness, whether it is a right-sided aortic arch, a left-sided aortic arch, that you can look at the aortic shadow. And carefully look at the lung vasculature and the parenchyma and the bony cage deformity, that itself will be a restrictive lung disease, or the diaphragm, whether there is a CDH or a diaphragmatic palsy. This is a uniform ground glass appearance of the lungs in RDS. And you see the streaky pattern with the fluid in the minor fissure in TTN. And this is a patchy areas with the meconium syndrome, and pneumonia is like a lobar or atelectasis in pneumonia and atelectasis, and air leak syndromes with the pneumothorax with the collapsed lung, and diaphragmatic congenital anomalies, CDH, you're seeing the intestinal loops in the chest, and congenital pulmonary airway malformations, and also congenital lobar emphysemas. And in heart, you can look at the shape and also look at the situs. This is a situs inversus totalis. You see the liver on the other side and the heart on the right side, but liver might be on the right side and the dextrocardia will be there. So when these situations, isolated dextrocardias is a little bit more than more associated with critical heart disease than just isolate like a situs inversus totalis. And the boot-shaped heart and snowman appearance in TFPVR and egg-on side in TGA, and a huge cardiomegaly in Epstein's anomaly and the tricuspid atresia, or a PIE picture, or a hypovolemic situation with a squeezed heart, or eventuation, or diaphragmatic palsy. So when you see all these abnormalities in X-rays, it may direct you what you are dealing with. But sometimes you don't find anything. And you also need to think outside of the box, like it could be just sepsis, or it is a sugar issue, or it is a metabolic issue, or hypocalcemia, or is it pain related, or fever, or this is environmental temperature related, or there is a withdrawal due to maternal medications. So we have to keep everything in mind. So we are ruling out one by one, and but you have to think outside of the box if something is not fitting with the baby's condition. So these are some other red flags for critical congenital heart disease. Yes, cyanosis with the happy baby with the tachypnea, and that is because of increased congested lungs secondary to the cardiac and hemodynamic circulation. You have a murmur, a significant murmur, more than 3/6, or continuous murmur, or radiating murmur, that is significant. And also, if you see a normal lung with the low PaO2, you cannot explain why the PaO2 is low, and always think about the heart condition. And you have a situs inverse, situs normal, but you have a right-sided aortic arch. You see the right-sided aortic arch is here, and this also associated with critical heart diseases. So also, when you look at either you may see the lung, the X-ray in the pulmonary fields, the oligemic lung fields with or without murmurs. Like if you don't have a murmur and the X-ray looks okay, but you always think about like what we are missing, why this baby is having a cyanosis, why this PaO2 is low, and always look at whether there is an element of oligemia in the X-ray or not. So these are all the subtle things that we need to look at. And the next thing is the ECG, ask for a 12-lead ECG, and anything when you see in a newborn baby, the axis is in the lower, like from 62 up to 190. But if you see a superior axis, that is a red flag of we might be dealing with a critical congenital heart disease. Coming to the echocardiogram, this is the more definitive. And if available, always you should ask for it. And you can exclude several or almost everything except in some dilemma in very less frequent cases, but majority of the time you get a diagnosis. You can rule out confidently and what is going on. And in most of the centers that now the pediatric cardiology is available and echo can be done, but in some centers you have like adult cardiology, they can also do and rule out some critical cyanotic heart diseases. The second important test is the hyperoxia test. This you can do at the bedside. You administer 100% oxygen for 10 minutes or 10 to 15 minutes and look at the pre-ductal PaO2. You can give a hood oxygen, or if the baby is intubated, you can increase the FiO2 to 100%. And if the PaO2 pre-ductal arterial is more than 300, it's pretty normal. If you have a PaO2 more than 150 but less than 300, so could be pulmonary or CNS or hematological disorders like methemoglobinemia. If between 100 to 150, it could be a PPHN or cardiac mixing lesions with increased pulmonary blood flow. And if it is less than 100, is a critical heart disease with restricted pulmonary blood flow. So, but always look at the hyperoxia test that you should be interpreting a little bit with caution, but there will be some overlap physiology might be there too. So there are some examples I could give, like in a TFTVC, when there is a large pulmonary blood flow, and that might not behave like a critical congenital heart, it will be behaving higher PaO2 because there's so much of a pulmonary blood flow is going on with the getting oxygenated. On the flip side, in a lung that there is a marked intrapulmonic shunt, that can behave like a worse BQ mismatch and may behave like low PaO2 with, and we may point towards a critical heart disease. This is some examples. So always keep a look at it. This is a screening tool, but you have to interpret with a little bit caution. And this is the algorithm. If you have a cyanosis baby with no respiratory distress, and you have a peripheral cyanosis, what we saw, which is normal, reassure and warm the baby. If you have a central cyanosis, do a hyperoxia test. If you have a differential diagnosis, definitely you need to go to a cardiac evaluation. And if you have reverse differential, again the same. But if you have a baby who have a respiratory distress with no obstruction, like upper airway issues, and go for hyperoxia test to rule out whether it is pulmonary or cardiac. But if there is an obstruction, then give oxygen, give PPV, and go for ENT evaluation, like for upper airway obstructions. And in hyperoxia test, as we have discussed, administer oxygen for 10 to 15 minutes and the pre-ductal PaO2. If it is less than 100, it is a cardiac. So you have to do the cardiac evaluation. And also, if you are going down the road, consider starting prostatic infusion and look at the PaO2 increase. And if it is 100 to 150, I'm sorry, this is more than, and it is PPHN, or we need a cardiac evaluation. Some overlap physiology might be there, and decide on whether to start on prostatin or not, depending on the situation. Once you start and see for the response. If it's a PaO2 is more than 150, it's a respiratory cause, and start oxygen and PPV. This is a sample algorithm. But our goals of therapy in any setting is we need to initiate all the support before reaching a definitive diagnosis. We may not be able to reach a definitive diagnosis before starting or initiating the treatment. So always do a comprehensive assessment of airway, breathing, and circulation. Assess the oxygenation level and provide adequate oxygen. Measure the arterial PO2 rather than just depending on only SpO2, because SpO2 may reach 100%, even still that the PaO2 will be still 60 or 70, that's all. Any suspicion of cardiac, involve pediatric cardiology earlier. In any setting, a remote resource limited setting, call NEO for help. The goals of therapy is go with adequate temperature control, optimize the hematocrit, optimize the hematocrit, ensure adequate systemic perfusion. You may need to administer some volume or vasopressors, optimize the ventilation support. If required, initiate a mechanical ventilation, sedation, or pharmacological paralysis. Reduce or eliminate acidosis, ensure normal sugar level, normal calcium level, ensure adequate pH and pulmonary vascular resistance control. These are all the goals of the therapy in any ICU setting. And do not wait for the definitive diagnosis. If you think about is a cardiac, if a PaO2 is less than 100, you need to start a prostatin. Start at 0.05 microgram per kg per minute. And the ductal dependent lesions will improve. The non-ductal dependent lesions might not show much improvement. That's fine. But this is safer to start than waiting. But only in certain situations, right? Like TAPVC with obstruction, when you start the PGE1, you might see some deterioration. When you see anytime there is a deterioration, you might wean and hold off and get immediate assistance from cardiology or from NEO. The last is the critical congenital heart disease screening. 1 in 4 babies born with heart defect has a critical congenital heart disease. By physical examination, we may pick up to 50%. Since 2012, both American Academy of Pediatrics and the Canadian Pediatric Society had endorsed critical congenital heart disease screening as a whole nationwide screening program. Adding this screening program at 24 hours of age would make this detection close to 80%. Still, we have a room to, because the babies are getting discharged at 24 hours. So those who are not yet implemented this program, it is beneficial to implement. It is very as simple as looking at the pre-ductal saturation and the post-ductal saturation and putting, how much is the difference in pre and post. If it is a more than 3% difference, we need to repeat in 1 hour. It's not only more than 3% or is less than 95% and more than 3% difference. If you repeat and if you still see the same in the 3 readings and it is failed screen, you need to refer immediately to cardiac assessment. If you see more than 95% and less than 3% difference and this is passed, and 80% of the time there is no critical congenital heart disease in first 24 hours. So this is a fantastic tool. We are all using this tool before the baby goes home. So this is from Focus Neo. We have made this tool. The CCHD screening is a free access. You can use this tool, and it's a calculator. You can put the right hand and either foot. This is a postductal, this is a preductal, and it will give a result. And also you can put the 3rd reading, and then it will give whether normal, passed, or not passed. Back to NICU with Sarah. We already know that Sarah is showing signs of respiratory distress and cyanosis. Based on what we have learned about cyanosis, we know that cardiac and pulmonary causes are the most common and can be life-threatening. We still need to check oxygen saturation and to get a 4-limb BP. Initially, her SpO2 was 85% on room air, but subsequently we gave oxygen therapy and did the hyperoxia test. The saturations improved to 97% after 10 minutes of 2-liter oxygen. And the blood gas revealed a PaO2 of 220. Given the positive response to oxygen, her normal cardiac exam and abnormal respiratory exam, you are leaning towards respiratory cause. You order an X-ray, chest, CBC, gas lactate, and glucose and ionized calcium, and blood cultures. X-ray revealed that the heart appears to be normally shaped and a CT ratio of less than 50%, and the lungs, however, look abnormal with diffuse patchy areas with no evidence of pneumothorax and no focal consolidation. Her CBC is within expected range for a newborn, and her blood gas shows she is retaining CO2. Some pertinent positives in this assessment, which includes the term baby with the dark stained amniotic fluid, respiratory distress with improvement after supplemental oxygen, and abnormal appearing lungs on the X-ray. With this mind, your top differential is meconium aspiration syndrome. You have kept Sarah on supplemental oxygen and decided that she is stable without more aggressive form of respiratory support, but still under monitoring. You are very happy to present these findings to your staff about your management. In summary, the evaluation of a cyanotic newborn includes assessment for respiratory, cardiac, neurologic, and hematologic disease. Respiratory disease is being the most common. History and physical examination will guide the initial diagnosis. A chest X-rays, hyperoxia test, and pulse oximeter screening may add additional information. A definitive diagnostic test for CHD is echocardiography. And a prompt identification of a ductal dependent lesion is essential for effective treatment and may initiate oxygen, breathing support, and plus or minus prostate infusion when indicated. With this, I conclude this lesson. I hope you enjoyed the presentation. Thank you for your kind attention.
Thank you. Thank you very much. Illustrative, very illustrative presentation. And I have just one question, Dr. Muzafar. If because in our unit we started with the lung sonar in unit, I don't know if lung sonar has any role in this dilemma of congenital cyanotic heart disease or cyanosis in general.
Excellent.
Beside X-ray, yes.
Yeah. Thank you so much for a fantastic question. Actually, so the role of a lung ultrasound. So in lung ultrasound is we are moving away from the lung ultrasound into chest ultrasound. Okay, so there are three components. We can just go with the parenchymal assessment, lung parenchymal assessment. So you see here, there could be a pneumothorax that can be diagnosed by lung ultrasound.
Yes.
Okay.
Yes.
And if you have RDS or PPN, yeah, you can differentiate there. Okay. A normal lung, like in a cardiac, a normal lung where we have a pure A lines and there is a no B line that shows very aerated lung. So that rules out the pulmonary pathology. That is an important finding. Okay. Or a congested lung, because the heart condition, you have a increased pulmonary blood flow. You will see more B lines in a healthy infant. That is also a sign that you are dealing with more interstitial fluid.
Yes.
So definitely the lung parenchymal assessment, the lung ultrasound is contributing a lot. Okay. Second is the diaphragm assessment. So in a more advanced user, you can also look at the diaphragm. You can diagnose if there is any CDH, if there is diaphragmatic movement, if there is a palsy, like eventurated diaphragm or diaphragmatic palsy, that you can still diagnose. More advanced is, now Yasser is here, he is expert in upper airway ultrasound. So we can even diagnose how is the upper airway. You have vocal cord palsy or not. Okay. Or this one can be assessed with the lung ultrasound. It's great to hear that you are more advanced with the bedside ultrasound, and there are a lot of information we can get from lung ultrasound. And definitely when somebody is expert in lung ultrasound, it's very easy to look at a basic few views to rule out a structurally abnormal heart for a critical congenital heart. So those, our team, we can still train for basic views to rule out a critical congenital heart with looking at a few views. That also will add value. Thank you. Thank you. It's a fantastic question. Thank you so much.
Dr. Sam, if there is any questions from attendees or from our colleagues? Or
yes, please. Can I ask a question? I'm Dr. Salma Al-Houshi. I'm Dr. Salma Al-Houshi from Cairo University, and I have a question about administration of Prostine, because it's been like a routine now in our unit is that they add something to help with the apnea. They usually add caffeine citrate. Is this like a routine thing? How, or otherwise, how can we help with the apnea induced by the Prostine?
It's a very good question. So there are, when you administer Prostine, you expect some vasodilatation, cutaneous vasodilatation, and fever, and apneic spells. This is the most common side effects. So in a controlled ICU setting, you don't need to intubate before starting Prostine. Okay. But if you are in a resource limited setting that you cannot manage the emergency, and it's better, make sure that you have all the intubation ready if you are starting the Prostine. Or if you are sending the baby, transporting to a different center, it is better to intubate and transport the baby. Okay. So when you look at, that's why, like when you look at the 0.05, when you have a response, and always we try to come down, not to keep the same dose. If you see the adequate response, and then over the time we started to come down to lower by gradually weaning down to even to 0.01 to maintain open duct. Okay, so this is to minimize the impact or side effect from the Prostine. But this is not like in a critical situation that you can start and you can prepare if there is an apnea for intubation in ICU. But if you are in a resource limited area and you are worried that they cannot be able to cope up with the apneic spells, and then you can prepare for intubation before starting Prostine. I hope I answered your question.
Maybe okay, thank you.
Yeah, can I just add a quick note for that? Yeah, thank you very much. caffeine has been validated as a medication for apnea of prematurity. We are not really actually sure from evidence that caffeine might be appropriate for prostaglandin-induced apnea. Yes. So in our sitting here in North America, we consider early surgery. So the infant would be really a candidate for surgery within probably 2 to 3 days after diagnosis of congenital cyanotic heart disease. So early intubation after, like, we should not consider intubation as a routine with the prostaglandin, but once the infant started to be apneic, we consider intubation because typically he will be a subject for surgery within like 2 or 3 days. We are not considering prostaglandin more than like a week waiting for surgery unless there is other contraindication like low birth weight and he's not for surgery for any other reason. So that's my intake. So I'm not 100% sure about the efficacy of caffeine. Probably your experience might elaborate that, but caffeine is a medication for apnea of prematurity. That's like what we know from validation. Thank you.
Okay.
Thank you, Asad. Thank you.
I think we have to move to another speaker, Dr. Sameh. تفضل الزملاء بقى.
Assalamu alaikum. I am Professor Maha Hassan. It's my pleasure to introduce Professor Dr. Yasser Sayed. He was graduated from Zagazig University, a master's degree from same university, doctorate from Azhar University. He's an associate professor of pediatrics at University of Manitoba, staff neonatologist, and founder and director of integrated hemodynamics program and point of care in Winnipeg, co-chair of Point of Care Ultrasound Focus New International Group. It's my pleasure to introduce him, and I am thankful to him for his knowledgeable lectures that we are always amused of listening to it. Tfaddal, Professor Yasser.
Yeah, thank you very much, Professor Maha, for the kind introduction. It's always a pleasure to collaborate and
دكتور ياسر بعد اذن حضرتك دكتور صفاء ليها تعليق كده